Next session. Chairing this session will be Dr. Pratibha Singhi ma'am, Dr. S. Sitaraman and Dr. Rajeshwari Armoganti. Dr. Pratibha Singhi ma'am needs no introduction. She is one of the great names in the field of pediatric neurology in India. Ma'am was the former professor and chief of pediatric neurology and neurodevelopment, Department of Pediatrics, PGI MER Chandigarh. Ma'am is at present a consultant in pediatric neurology, Vedanta, New Delhi. And ma'am has been the national president of the Association of Child Neurology in India. To her credit, ma'am has more than 250 research papers, 2 books, and more than 250 research papers in national and international journals. Dr. S. Sitaraman, sir is senior professor and head Department of Pediatrics, SMS Medical College, Jaipur. Dr. Rajeshwari Armoganti has been associated with the Department of Biochemistry, AIMS, and ma'am has been doing wonderful work with ataxia patients over the years. Over to you, ma'am.
Thank you. And as you all know, that this is a kind of medley session to bring out some important practice points. And we have a number of speakers, and therefore I have to, as a chairperson, request them to stick to time. And without much ado, I'd like to call upon the first speaker, Dr. Anil Israni, to talk about follow-up of high-risk newborn babies. Dr. Israni is a pediatric neurologist at Alder Hey Children's Hospital, Liverpool, UK. Dr. Israni, welcome.
Very good afternoon to this august audience, and thank you for the opportunity. Can I have the presentation? I'm not having the presentation on the screen.
Can we look at the presentation? Can somebody look at it?
Yeah. So in the next few slides, I'll try to cover what is the burden of problem, how do we identify and stratify the risk in a neonate, and what is the importance of diagnosing developmental delay early, and what are the commonly used screening tools, and what is the importance of using screening tools than just clinical judgment. What is the suggested structured follow-up plan for these neonates, and keeping in line with the theme of this conference, what are the emerging trends? In India, 20% of newborns are born low birth weight, which translates into 7 million new low birth babies every single year. Moreover, environmental factors like low maternal education and low maternal income, low family income also contributes to this. WHO estimate of prevalence of developmental delay is anywhere between 1.5 to 3%. But infants and neonates at risk are 24 times more likely to have developmental delay. And it's not just about its impact at individual level, it has repercussions on society and national levels as well in terms of provision of costs for healthcare, educational support and rehabilitation services. Apart from that, there are indirect costs involved in loss of productivity. We are also aware that the advances in neonatal care have not led to corresponding decrease in morbidity. And therefore, it becomes important that we identify this early so that we can use this window of opportunity where neuroplasticity is at its peak in the first 2 or 3 years of life. And early intervention has now, we have evidence that has led to improved outcomes and can reduce complex or severe disability by 10 to 40%. So we have all reasons to diagnose developmental delay early. We have this information from National Neonatology Forum regarding stratification of risk factors in neonates. Sometimes neonates may have more than one type of risk factor. In that case, the higher risk category should be attributed. There are 3 primary ways in which we can follow children at risk for developmental delay. One is surveillance, which just means an informal longitudinal process of monitoring the child's development over time. by just clinical judgment, which would include history and observation. Whereas screening uses brief standardized tools that serve to identify developmental delay. However, it is also not diagnostic. Whereas evaluation and assessment using complex, detailed, and time-intensive process leads to a formal diagnosis of developmental delay. Interestingly, a survey was conducted in the US way back in 2005, and the study found that only 71% of general pediatricians use the clinical judgment without using standardized screening tool. And what happened as a result that only 30% of children with developmental disorders were detected prior to 5 years of age. And the reasons that were found for underutilization of developmental screening tools were lack of time to administer a screen and lack of training. And hence this importance on developing a simple screening tool which can be administered by people at the ground level and which saves time. There are a number of developmental screening instruments, and many get added to this list every month. What I want to highlight on this slide is there are different screening tools for looking at different developmental domains. So for general developmental screening, we have DDST, which is the Denver Development Screening Tool. We have the second version now, the Trivandrum Developmental Screening Chart, which I think most of us are familiar with. The Bailey Infant Neuro Developmental Screen. For cognitive, we have CAT and CLAMP, so on and so forth. What is now emerging is reliability on parental information regarding developmental screening, and many parent-administered developmental questionnaires, including ASQ and parents' evaluation of development status, are now gaining importance. Very briefly about this commonly used tool, it can be used from birth to 6 years with relatively low sensitivity and specificity, 10 to 20 minutes time to administer. It has been normed on diverse populations across the world and tests across all domains. So essentially on the x-axis, we have the age in months and then going on to years, and on the y-axis, we have these developmental milestones. The gray area represents the 75th to 90th centile for achievement of that particular milestone, suggesting some caution. So the interpretation is either pass when the developmental milestone is achieved and demonstrated, fail or no opportunity or refusal in a clinical setting. Normal would mean no delays or maximum of 1 caution. Suspect would mean 2 or more cautions or 1 delay. And it is suggested to rescreen after 1 or 2 weeks, and sometimes it can be untestable when more than 1 item is intersected in the caution line of 75th to 90th centile. The other commonly used developmental screening tools in India are the Baroda norms and Trivandrum developmental screening tests. It is a simple chart consisting of only 17 items, and essentially we draw a line perpendicular to the age in months of the child, and the child should have achieved all the developmental milestones to the left of this line. I think it is a very simple screening tool, very useful, and it saves a lot of time. The formal developmental assessment tool used in India is Developmental Assessment Scale for Indian Infants. It is the only validated tool for developmental assessment in Indian infants. And essentially, it is adaptation of BSID, can be used up to 30 months of age, and it gives us a developmental quotient in the motor and mental domains. There are 5 motor clusters and 10 mental clusters across 63 items on motor cluster and 167 items on the mental clusters. So it is quite an extensive, intensive, and time-consuming test. In my personal experience, I think there are a few practice tips that I would like to share with you, is that it's very important that with this number of screening tools available, we select the right screening tool. Before making a formal developmental delay diagnosis, it is important that it is done in the right setting. Parents should be engaged in the process, allow enough opportunities before saying that the milestone is not demonstrable. More the assessment is done in a play way, more likely it is to be successful. And it's always a good idea to repeat assessment at a later date if we are unsure about the findings. In a clinical setting, elicitation of developmental milestones in children can be challenging, and it's very important to have a very keen observation while child is observed in the clinic for developmental milestones. I'll also talk about setting up a follow-up services. Of course, it has to be multidisciplinary approach with a dedicated team from across various specialties. A neonatologist or a pediatrician can be the nodal person who orchestrates the overall developmental follow-up, of course, with inputs from pediatric neurologists, clinical child psychologists, early interventionists, physiotherapists, occupational therapists, dietitian, ophthalmologists, an ENT specialist, and a medical social worker. Other two important practice tips are for developmental milestones, anthropometry, and introduction of complementary feeds, we use the corrected age for gestation, whereas for immunization, we use the chronological or postnatal age. The suggested follow-up schedule for high risk and low risk is like this. So after discharge, an early follow-up for the high risk infants is suggested to identify any early medical problems, followed by every 2 weeks until 3 kg weight, and then 3 monthly in the first year of life, followed by at 15 and 18 months, and then every 6 months till 8 years of life. This is because subtle neurodevelopmental problems, particularly with language, cognitive, and other domains, can be identified as the academic challenges increase when the child starts schooling. For low risk, we can have a less frequent follow-up 2 weeks after discharge, followed by at 6, 10, and 14 weeks, which is in line with the vaccination schedule, and then at 3 months interval in the first year of life, and then every 6 months till 8 years. Of course, more visits can be planned if required. The activities undertaken on each follow-up would be, let's not forget the basics: assessment of feeding, dietary counseling, growth monitoring, immunization, ongoing medical problems, followed by a thorough neurological examination, preferably in each visit, and a developmental screening in each visit. Formal developmental assessment, which is DASI, can be first done at 3 months of age to diagnose developmental delay early. And if there is any problem detected in the first test, then the test can be repeated at 6 and 9 months. Otherwise, it can be just done at 12 months, 18 months, and subsequently at around 30 months of age. Hearing and ophthalmology screening are part of developmental screening and assessment and should be undertaken. For muscle tone problems that we are worried about in infants who are at risk of developing cerebral palsy, Emil-Thiessen score is very useful. It basically looks at these different angles, and there are age-specific norms. Typically, an infant would have hypotonia to begin with, and then the tone would evolve into spasticity in the later 6 months of the first year of life. This is the suggested plan that all infants who are registered in the high-risk follow-up clinic, they have their developmental surveillance and screening at every visit, DASI at 3 months of corrected age, and if the developmental quotient on DASI is 85 or more, which is normal, then the clinical team continues to screen developmentally at each visit. However, if the score is less than 85 or there are any concerns by the clinical child psychologist, then referral should be made for early stimulation and intervention. I would also like to highlight here that we need not essentially wait for the first 3-month assessment of DASI for early referral for stimulation and intervention. It can be done even earlier, and I'll come to it in a bit. Two-stage screening for hearing has been suggested, first by autoacoustic emission, followed by brainstem auditory response, and this approach has shown to reduce false positive results. A routine ROP screen for all preterms is as per the protocol, but on each follow-up visit, a detailed ophthalmology history asking about simple questions like visual fixation and tracking is important. Something as simple as torchlight external examination of the eye can show cataracts or some evidence of anterior segment abnormalities of the eye. And if any problems are found, then appropriate referral and early visual rehabilitation should be instituted. I shall also discuss in the next 2 or 3 slides about the emerging trends. Now, there is some evidence that the nature and quality of spontaneous movements in the neonatal period can predict motor delay, particularly if they are abrupt and synchronous. And now there are some scales available looking at different characteristics of these spontaneous movements like velocity, kurtosis of acceleration, and movement units in limbs, which can predict motor delay. And if these scales are found to be reliable and valid, then perhaps it makes a case for early institution of interventions beginning in the neonatal period itself. How early really is the question, and ideally rehabilitation begins in the NICU itself for all the neonates who have high risk. Conducive environment in the NICU with ambient light and sound levels does affect later communication development. Good postural measures, oromotor stimulation, and encouraging baby-mother interaction.
You have just 1 minute more, so please.
I'll wind up. Also assist in having good developmental outcomes. As Professor Gulati already mentioned about this, there is now emerging trend about the use of parent-administered questionnaires, as well as adaptation and validation of internationally used developmental screening tools in Indian context. I think that's all I wanted to share with you. Thank you so very much. I welcome any questions, comments, or inputs.
So thank you very much. I think we'll take the questions after the second speaker.
Thank you so
I've
much.
just received an SOS. We'll have to change the session, and we are running really short of time.
Absolutely.
So
Thank you
we'll
so
take
very
the
much.
questions after the second speaker.
Thank you so much.
Thank you.
The next speaker is Dr. Asha Chetnis. She is a physiotherapist, pediatric physiotherapist, and is a director at the Pediatric Center of Vedanta at Mumbai.
Good afternoon, distinguished guests, chairpersons, my teachers and colleagues. I'm a pediatric therapist, and what I'm going to really talk today is what I really do in the NICU and how I work in the NICU. I always thank my teachers where I really stand tall on their shoulders. So what is the plan? Basically understand what is early intervention, what are our goals as a therapist, what's the team approach, how do you really pick up early delays, how do you harness neuroplasticity, which is a game changer. We heard Dr. Biju speak about it. And I guess the most important thing that we've been listening from yesterday is how parents are a great asset. If you really look at the burden, India has a huge burden of preterm and HI deliveries. Having said that, let's understand what is early intervention. It's basically nothing but a coordinated services which helps you to really pick up age-appropriate growth and development and support families through the critical years. The most important thing, a takeaway from this slide is how is early intervention defined? I think so this picture gives it to you, that how early it is to use the advantage of neural plasticity or brain plasticity. You see what happens in the newborn, and look in the first 2 years, how rapidly it is and how important it is to start early. And if there is a diagnosis late, what happens then? And what are your aims to use that intervention? What are the aims of interventions? To improve motor control, basically to look at physiological stability, attachment and bonding, oral feeding, physiological stability, weight gain, and cognition. There is a lot of research due to a lot of time. I'm not going to really quote lots of papers, but if you really look at the different interventions that you have, and these are all papers from last 15 or 16, there are active movements, there are passive movements, there is massage, there is parent-infant bonding, task specific environment, and motor interventions. There are huge things that are going on. Where do you implement intervention? Is it in the NICU? Is it at home? Is it at clinic? Is it at the hospital settings? And when to begin intervention? Immediately at birth, at specific age, when the baby is stable, or at the hospital discharge? I think so what is not really clear with so much of research that is going on is there is no real consensus when I really went is how much should be the duration and dosing of the interventions is important? Is the length, the number of sessions, and the duration of intervention? There is really no clarity on that as yet. So my speaker first spoke about the team approach. Yes, this is a huge team approach, and every team out here is extremely important. And as time goes by, we can't forget the developmental pediatricians, the family support systems, the orthopedic surgeons who really give you a comprehensive team approach. we're really not looking at survival, we're really looking at intact survival. What do we as therapists really do? There are three things that we do. We really basically look at posture and alignment, we look at oromotor skills, we also look at musculoskeletal problems or any iatrogenic orthopedic problems that we do. I spent my time in Seattle, and one thing I learned from my mentor who's written the APTA guidelines, and she says, where do we start? And I think so the most important thing is do no harm. You have to adjust your approach to fit the infant. As therapists, you also need to understand when we touch an infant, we give sensory input. You need to understand how much is too much, how much is too little, and how much is appropriate. I think so he also mentioned, my speaker earlier, that the developmental supportive environment is what you really need to understand, the amount of light, how you speak, what should be the sound, what it should be. So these are important things prior to really looking at a baby. Always understand their arousal states, the cues. Basically understand, is the baby crying and fidgety, or is it active, alert, sleepy? Because I tell you, when you look at babies who are crying or alert, they are your first signs of neurological insult or trying to say that this baby could be at risks. Now, what is my toolbox as a therapist? I basically look at positionings, handling, chest PT, outcome measures, and how do I educate my parents. We all know that we develop cephalocaudal, but tone intrauterine develops caudocephal. So if you look at the first on the extreme light, at 28 weeks you have tone at the ankle, by 30 weeks it's at the hips, and by 32 weeks it's at the upper extremities, and by 40 weeks is what you have a flexor recoil, and I feel physiological flexion is very important, or a big precursor to normal development. Today we are salvaging very, very premature babies, and that's why there are 100 lines there called the spaghetti syndrome. I guess what we need to understand, this is a full-term baby who can really look, orient, tuck his body, and if you look at the other video that's playing, this is a premature baby, and what it really shows, or a preterm baby, is tremendous asymmetry and difficult to interact with gravity. The other problems that we face is when you have so much of ventilation, you have these W positions, and hence, for me as a therapist, what really comes in my way is midline orientations. All my babies really start with a lot of problems with self-regulation, respiration, and all these little things can lead to secondary problems. The other comorbidities could be torticollis that I see. Hence, how do you really position the baby in the NICU? Take a toy, use the flexor recoil, use these bed sheets, and kind of work in the semi-sideline position. There are many other adjuncts that you can use. It could be nesting, swaddling. Kangaroo care is really good. We really enhance that work because it's a lot of sensory input and a lot of bounding that happens. At the end, what I do by achieving positioning is I really reduce my hyperextensions and elevations of shoulder, and basically in bottom line get a lot of flexion that's required for a preterm baby. Bonding is very important, specifically with parents who've really had a tough time. Just cooing, talking to them, cuddling, I guess helps a lot of bonding. If you look at chest PT, what are the things that I do in chest PT, and why do I do chest PT? These are all the equipments which I'll talk about. Basically, the problems that you really face, and as I'm called in the NICU, are hyaline membrane diseases, pneumonia. You could have bronchopulmonary dysplasias and meconium aspirations. What do I do by doing chest PTs? Basically, take care of the patent airways, facilitate secretions, re-expand collapsed lung segments, improve breathing, and post-extubation. Who don't you do? What are the contraindications? Babies who are unstable, less than 1,000 grammars, you can't give head-low positions. Anybody who's got intraventricular hemorrhages, anybody who's got cardiac problems, eye surgeries, and abdominal distension. This is what we do. We sometimes give nebulization through ventilator, or I use a ladle face mask, which is on your preterm ambu bag. I use that. We also give steam. The other thing that we do is I use the same ladle face mask to give a lot of vibrations. That helps me give chest PT. If you have fancy neonatal cares, you have vibrations. When you don't have all this, what we really do when we are working at small setups is I ask people to autoclave nipples, and nipples also gives me the same position, and I can use chest PT. If I have a very small baby, I use small vibratory brushes, which I put Gamzee, and that helps me to do a lot of chest PT. If the patient is on ventilator, we use the normal suction, otherwise we use a mucus extractor to basically suck. Having said that, these are positions that we put it in the NICU for all of us to know what we are dealing with. When I was working in Chicago, this was what my teacher taught me. It's so beautiful. We have these early delays. Look at a 4-month baby who's got lovely midline, lovely anti-gravity flexion versus a baby who has a problem, just does not have any anti-gravity control. This isn't supine and prone. If you look at both of them, his hips are up, there is no head control, versus the baby who's normal has lovely prone arm weight bearing. If you look at a pull to sit, look at both the babies and look at the head lag that the baby shows versus how well the baby comes. These are real high pointers that can pick you up. Look at him in sitting. This is a 4-month-old. He can sit so well versus the baby who has a problem has so much of bobbing. So these are real indicators. This is kind of horizontal suspension. You can look at how well he can extend versus a baby who just cannot get his trunk into extension. Having said that, we have an OPD where we have passport status where I work in Mumbai. The sisters would do head, chest, length, weight. What are the early signs? If babies come with feeding problems, sleep cycles, increased tone with any activity, a lot of retraction, persistent hip flexion, and no head control are problems. What are your sensory and speech problems? Face interactions, cooing, latching on a nipple. Mother tells there are so many problems, feeding problems, the volume that they take, they just don't like the nipple in the mouth, don't enjoy any textured toys, basically don't even follow or track, and not even reaching for toys. And once we know, parents are very integral, and what I want to convey out here is when they have a baby, they're so happy, they're secure, and there's a lot of work that says that there are lots of psychological effects on parents. I think so attachment is a problem, bonding is a problem, they're always in depression. There's a huge impact because of all this on parent-infant relationships, and I think so the most important take-home for this part is always sit down, have a good communication, interact, spend some time every day, make it a point to really support parents, form small support groups that really helps. I'm quickly going through what you do when the baby is born. You do tummy time. Parents are very scared to put them in prone position, but tummy time is an important aspect. A lot of kids today born have a reflux, so just making a proper pillow, making it to 45 degrees helps the feeding procedure. Looking at vision, working on vision, and also calming the babies who are having a lot of arousal problems. Using your own body to give movement really helps them calm their system down. Quickly, I mean, we've heard our esteemed speakers speak about a lot of outcome measures, but as a therapist, I basically use 3 things. I'm trained to do test of infant motor performance, and what it really tells you is that it talks about the control. The test has good reliability and good validity. There is an inter-reliability. So the reason I like this test, this is the only test that allows me to look at babies at 34 weeks of gestation to 4 months. Once you have got this, what you really do are there are 13 observed and 29 elicited items, which has 0, 1, 2, 3, 4. That's a lovely graph that you look at. And if you look at the pink version there, if your baby at full term by 40 weeks is below the 25 percentile, the baby is going to have a lot of problems as development goes by. The other good thing that you need to train about is GM. It really is highly sensitive, but you need to be formally training it. This is good because once my baby is full term, I can use it from full term to 20 weeks. It tells me 2 things. Is the baby showing you a lot of fidgety movements, or is it going to show you a cramp synchronized movements? Because they are highly indicators of spastic CP or dystonic CP. So these are things that you watch for. Once you are crossed that 4 to 6 months, you look at the Albert Infant Motor Scale, which really looks at 4 domains basically. It's the supine, the prone, the sitting, standing. You look at every picture, it comes with that, and you really say, is the baby doing it? Yes or no is all you do. You go back and plot all that points, and then you really look at where your percentiles are. Alberta, TIMP, Alberta, GM, there's a lot of correlation, lots of work that has been done. So at least till 18 months, you know where your child is going, how you are going, and that really basically helps you to understand what happens as a therapist. So if I have to really conclude my talk today, we India are the largest contributor or burden of prematurity. We still lack adequate facilities in large parts of our country. Early intervention is really shifting now from the infancy to NICU. And not only that, it's also from the antenatal to natal period. Prevention is also always better than cure. It starts before conception. We have to always maximize the benefits of neuroplasticity. Little extra care in the newborn period can change the life of the patient and their family. And I think so empowering parent and child relationships is very, very important. Thank you so much for a patient hearing.
Thank you, Asha. Now, you will all agree with me that both the speakers have very nicely summarized neonatal follow-up and intervention respectively. I would just like to make a comment that, both of them have talked about screening tests and examination and assessment tests. As a pragmatic person, you must be comfortable with the test you use. Some of these tests require training. We shouldn't sort of get swayed by newer tests that come. And unless you are, very comfortable and familiar with the test, sometimes, just skimming through it may not be the right way. So I open the floor to any questions or comments, quick ones for 2 minutes for both the speakers. Any questions or comments? I know everybody is hungry, waiting for lunch, and that's why the organizers have decided to terminate this session after this and then carry it on later. Biju, please.
Thanks, Asha. Just a little comment. I can't stress enough the importance of observing the movements of the child, which Anil also did in one of his slides towards the end. He probably didn't get time to elaborate. But observing the movements is very, 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 very important. And that is where you need to, you will pick up the difference. Because some of how the movements develop and the normal development and also the pathological development, some of the ballerina poses which babies do, we can see exactly the same poses in DYT1 mutations. So it's so important to detect the movement pattern. Also, the other important thing is we always talk about secondary dystonias having very poor outcome. But that's because these babies have never experienced normal development. So the important thing is if you catch them early, and if you give these babies a chance to experience the normal motor development, obviously that's going to make a big difference on the outcome. Thank you.
I think I second Dr. Biju's comment on this, and I usually insist upon my residents to do what he is exactly mentioned, that you observe the newborns and in your nurseries, just understand the normal movement. That's more important. It comes by experience. It doesn't, you can't learn it from, you can't be taught to look at that. You keep on observing normal babies and then observe, suddenly you start discovering that this child is moving in a very different manner. And that is the first sign, because touching and finding tonal abnormalities, checking the angles, amyl tyrosine is not really going to tell you everything. The observation of the child is extremely important. And I think the take-home message, especially younger colleagues, is that keep your eyes open when you're having the newborns, the normal newborns first, please, and then proceed to see how they are behaving. Thank you.
Excuse me, sir. I'm Dr. Vijay Mathur. I'm pediatric dentist by profession. And I'm here, I have to speak a little later. But there is one thing which I wanted to bring it here for the neonates is when we talk of oral motor functions and when we talk of latching, we often forget, nobody mentioned about the tongue tie. If the tongue is tied, the child will not have latching. It will take a lot of air in and there will be regurgitation. So we are working with our colleagues in neonatology in AIMS, and we are trying to identify it early and treat early. I do operate them at a very early age for the tongue tie, and that's what we have been getting little good response from people.
But I must say that, that's quite a controversial topic. And unless it's of a significant degree, because people have gone the other way around, the pendant goes like that. So many people have ascribed, tongue tie, and there are people who are operating day in and out. And the literature is yet to show how much improvement would it occur. So if you are doing in a very select population,
yes, ma'am.
That's fine.
That's what.
But I would like the audience to just be aware that you have to be extremely selective.
Exactly. All cases doesn't go for that.
Yeah. Thank you. So I think we need to break up for lunch, and the organizers will inform when this session will continue further, because we have another speaker coming after lunch. Thank you very much indeed.
So welcome back after the lunch. We'll be resuming our session. So I would invite Dr. S. Sitaraman and Dr. Moganty to kindly come on the stage and resume the session.
Good afternoon, all of you. I think you had a good lunch. So we have more interesting sessions in regard to some of the critical issues we have, especially from the sciences which are not basically pediatrics. So we have the first speaker is Dr. Deepak Gupta. He is head of the neurosurgery department in All India Institute. And I would request all the speakers to stick to the time schedule so that we can proceed in a quick manner.
Thank you, respected chairperson and the August gathering. When I entered the hall, I was hearing a lot of scientific deliberations about mitochondria, DNAs and other things. And me being a pediatric neurosurgeon, I just questioned myself if I am in the right place or not. Having said that, do I start करना?
लैपटॉप खोल दीजिए लैपटॉप.
All right. So I'll be very brief. I'll be just quickly sharing our experience with the craniopagus twins, which we recently separated at All India Institute of Medical Sciences last year. Well, as some of you might be knowing, this is an extremely rare condition. For every 25 lakh live births, there is one child born with this condition. And on the top of that, over 75% of these children are actually dead within 24 hours of birth. So this itself speaks about the rarity of this craniopagus or the conjoined twins which are joined at the head level. On the bottom, you see these Tatiana twins from the Canada. These girls are also called as the inseparables because they are sharing a thalamic bridge. And one girl, when she swallows some water, the other girl feels the sensation. And so much is the complexity involved between the two brains. On the top right, you see these two girls, the Ladan and Leheb Bijlani. These girls were recently operated in Iran, the Iranian twins, but unfortunately they died on the table. If you talk about the literature, more than a century, almost over 100 years have passed, and we have got around handful of survivors. Less than 10 plus survivors are there in the international literature as of today with this condition. The morbidity associated with this surgery is huge and enormous. If you talk about the Indian scenario, as of now, all the literature search and personal talks have been done to the people. We have a total of 6 sets of craniopagus twins, and all the children, they were either not operated, and when they were operated, they all died in our country. So these twins from Odisha district, they came to us last year. In fact, I was contacted in February 2017. They come from a tribal district of Odisha, the Kandhamal. And these are the Jaga Balia twins. They were united at the head fully. And this is their CT scan. Interestingly, it was a full-term normal vaginal delivery. And these children were never ever breastfed. You see these children, they were quite active otherwise. However, if you look them closely, one child was very comfortably lying down, the second child was crying. And there was so much of emotional mismatch between the two children while they were united. And interestingly, when I did the CD4 counts, they were completely different between the two children, 800 and 1100, though they were sharing the circulation. So this was an interesting observation I picked up in these children. So we had almost 6 months time in between to prepare for the surgical planning, and I did surgical risk stratification. And we subsequently made a huge team of almost 33 faculty and 42 residents to carry out this task. This was the first for the India, I would say that. And made a team and to discuss about the various issues of beneficence and non-maleficence, and of course the risk involved and the exorbitant costs with the surgery. And of course, we did talk to the various policy makers for this surgery. Subsequently, we did the pre-operative evaluation. The children had got some infective lymphadenitis, URTI, and they were quite malnourished, which were managed aptly by our pediatrics team. Later on, we went on and did the CT-based planning and 3D print models for these children. And this is how the CT scan looked like. The two heads were united to each other fully circumferentially, and this was very unique feature of this surgery. Later on, I went one step further, and I was, due to my close proximity to the people who are making these products in US, I could fuse the CT, MRI, and the angiogram of these children and come up with this beautiful model, the 3D print SLA model, wherein I could replicate the entire brain anatomy which was there in the children and could superimpose the angio architecture inside the model itself. And this model was subsequently autoclaved, and I could use it during the surgery while the actual separation. And of course, before the separation surgery, I did various hands-on robotic practice on the CT-based and MRI-based fusion models for these children to practice myself what is the best way I could do to give the least amount of deficit to the patients. Subsequently, we took these models which we made, and we took the children inside the theater before the actual surgery, and we practiced how to position the children on the operation table to be able to separate them. And this again took many meetings inside the operation theater. Subsequently, we decided to do something very different for our country. What we decided was to separate and to keep both the children alive, because they were sharing live circulation and the venous outflow was only one. So I went and approached my cardiac colleagues, and we could use a venous vein bank from a cardiac bypass patient, because a big, almost 18 centimeter vein was required inside the brain tissue to bypass the venous circulation. And this was a very innovative concept, I would say, which we thought about, because the veins are sub-millimeter in size, and it almost took us almost 8 to 10 hours. This is the venous bypass graft which we actually used during the surgery. And these are the tiny little veins of the motor strip veins which we actually used for anastomosis and for doing the venous bypass in the child. And all this planning was done before the surgery itself, after looking at the detailed angiogram of these children. And so the first surgery went off well. It took almost 25 hours for the first operation in continuous. However, the post-operative period was, I would say, the beginning of actual struggle. Because such operations, they give you a lot of fame. This is what I realized later on, because not many surgeries have been done. And then when suddenly you are aired on the BBC and newspapers and everything, then you can understand there is a lot of ifs and buts from your own team members. And then was the beginning of the stormy post-operative period. And I would say that a big thank you to the pediatrics team, because they were my rescuers, because all the kind of damage which surgeon does was nicely covered by our pediatrics team, because these children were in a very well-balanced kind of a fistula communication between the two brains, which was disturbed by us, because I did plan that I would do a stage separation in multiple stages and do a venous bypass so that they will have the least amount of deficit and I'll be able to save both of them. However, things don't go the way what we plan. So the child one, on the day one post-op, had a ventricular tachycardia. The other child had got refractory seizures. And of course, the venous graft on which I was heavily banking upon, it actually got thrombosed, which was quite expected. But I wanted the venous graft to fail after almost 4 to 6 weeks, because it is low flow system, but it failed early. Anyways, having said that, the entire pediatrics team came to our rescue, and so the one child was quite puffy and hepatomegalich immediately post-op. The second child was dehydrated and IVC was collapsed. So the child A was in pulmonary edema and the child B was in oliguria. So we had to manage the child in a very different way, but ultimately what was happening was, whenever we were giving fluid boluses to child B, it was worsening the pulmonary edema in the child A. So we had to do a very balanced approach in these children. The entire PICU team, pediatric neurology, pediatric nephrology, cardiology team came together, and we sat together and we studied the hemodynamics, what was happening inside. And so subsequently, we could manage these children in the stage 1. The one child had got refractory seizures, which was managed well by our pediatric neurology team. Again, the level of the anti-epileptics was going haywire. The serum epinephrine was coming out to be 0 in both the children. So we were not able to achieve the therapeutic consultations, but Shifali was quite smart. And so the one child had to be put almost on 5 anti-epileptics to manage the refractory seizures. The management of respiration again was an issue, because we were worried that one of the child, because of excessive sedation by the anti-epileptics, could go into respiratory depression, and we may have to intubate both the children at the same time. But we kept a very high threshold for intubation, and luckily we did not require to intubate the children. Can I have 5 more minutes? Is it possible? Otherwise, I'll just call it a day. Okay. Anyhow, subsequently, what happened was the children were doing well. I mean, for 2 weeks, they started gradually improving, and we tapered the anti-epileptic drugs for the children, and this is how the children look like 3 weeks after the surgery. But then when the problems begin on the day 1 post-op for a neurosurgeon, the problems continue. The skin expanders which were put by a plastic surgeon, one of the expander ruptured, and so the children had to be taken to the operation theater again for the expander replacement. 6 weeks later, when everything was falling back to the normal, we were quite happy. Suddenly, one child developed tachypnea, tachycardia, and gallop. We did an echo, and the echo showed the pro-BNP was almost 30,000, and myocardial function dropped down to almost 25. And our pediatric cardiologist managed the child, but however, EF kept on dropping to almost 25%. And he was the better child. So we were in a situation now, the better child, we were actually on the verge of losing when they were still united. So we decided with the ECMO support, with our cardiac team, we decided to go for a semi-emergency separation for these children. Exactly 8 weeks after the first surgery, we did the second final separation surgery, which lasted for almost 19 hours, and we could successfully separate both the children. And while the children were separated, there was a lot of adrenaline rush inside the operation theater, I would say, because everybody was so excited when the children were, I don't know if we have the voice here. Anyhow, so the children were successfully separated, and we were quite happy. And the child was rushed to another theater, but again, the better child developed a cardiac arrest. When he was still in the, it's okay, that's fine. So when we separated the child, the better child developed a cardiac arrest, and he was in the prone position. So here the pediatric cardiac perfusionist, the cardiologist, they came to our rescue, and we did the resuscitation of the child for almost 30 minutes. For 30 minutes, the good child was resuscitated, and our plastic surgery people were closing the skin flaps. So we actually did not know whether this child will survive or not. The other child who did not have a good venous circulation, we knew that we are going to lose that second child also. I'm done, I'm almost done. I'll just show you the happy childs. And so this is how the skin flaps look like, and all the skin flaps which were put in the children, they actually gave way because of the hypoperfusion. The child required hemodialysis for 7 days. However, our nephrology team, they worked very, very hard for these children, and these children, they actually made it, and gradually they started improving. We made endless helmet designs for these children, and this is how the children are now. I mean, 8 months down the line, the parental or the brotherly bondage has come up between the two children. This child has got some deficit still, while the other child has actually recovered very well. And he's quite active, playful with the nursing staff and with everybody. That's the deranged child, and he's also undergoing extensive neuro rehab care at our center. The development assessment done by Shifali is 75 in child A and 30 in the child 2. But this child is off tracheostomy, and he's being fed orally as of today. So I'll skip the literature. So last 1 year, I've been often asked this question, how are the children? Well, my answer to that is the children are doing absolutely well. And one child is doing well, and the second child is actually showing progress towards recovery. Though he may not come back to the normal life, I would say. This mission impossible task, I would say, was made possible with the support of our director and head of the department and chief of the center. And of course, with this big, huge team of 125 members, the Craniopagus team members, of which Shifali was a important part of our team. And so I would say that this milestone surgery for the country, the 2 lessons I have learned is that staging your surgery made the difference. And of course, we used a lot of technology and teamwork to be able to reach to a successful outcome. Like in international literature, we have got Ghost Twins, or the Great Ormond Street Children, or Children Hospital in Montforier. Similarly, now our children are known as Ames Twins in the international literature. And we have joined the success story on the Craniopagus twin separation for this country. And of course, it has also humbled me, I would say that, because the most hyped things about the surgery, they can fail anytime. Thank you very much.
Thank you very much. I'm sure, everybody has loved the story of the Ames twins, and it's a remarkable feat done by you and your team. And is there any quick question? Otherwise, we move to the next speaker. I think everybody is kind of overwhelmed by
Thank you, ma'am.
so much work that you did.
Thank
you
so
very much.
I appreciate it. And sorry for overshooting my time. It was difficult to cover this talk in 10 minutes. I'm
It's a
sorry.
very fascinating thing anyway.
Pleasure.
So I call upon the next speaker, Dr. Ramesh Konunki. He will apprise us regarding Botox current status, but I think the time has to be a little less than what was earlier planned, 10 minutes. And there's a lot to be said. I think people are familiar with Ramesh. He's a consultant pediatric neurologist at the Rainbow Children Hospital, Hyderabad. Ramesh, over to you.
Good afternoon, everyone. Next 12 minutes or so, I'll briefly discuss about the botulinum toxin, its current status, and where to use and where not to use botulinum toxin in children with static encephalopathy. That's the preferred term I use rather than cerebral palsy, but for ease of understanding, I'll still be using cerebral palsy. So I have no conflict of interest to declare and no financial support received from any pharmaceutical. So outline briefly about why do we need botulinum toxin. Is it really effective? Is it safe? And whom to offer and whom not to offer? So as all of you are aware, these are the common abnormal motor patterns in children with cerebral palsy. The first figure shows the equinus deformity, which is due to spasticity of gastrocnemius and soleus. The scissoring is because of the hip adductor spasticity. Crouch is walking with bent knees because of hamstring involvement. Whereas in these three patterns are commonly seen in children with either spastic diplegia or sometimes spastic quadriplegia with lower limb predominant involvement. The last one is the circumduction, which again has slightly different pattern of involvement. Coming to the upper limbs, the common patterns are either you have a dystonic upper limb involvement or spastic involvement. So looking at the posture, you are most likely you will be able to identify which pattern it is. So these are the common motor patterns which are the which interfere with either ambulation or the use of upper limb in children with cerebral palsy. So why do we need to treat spasticity? Because if you treat spasticity, it facilitates better mobility and ambulation and better dexterity for the hands. It improves posture, minimizes contractures and deformity. This is often not visible directly, but over the long run, you see that these children have less contractures and less deformities of the limbs. Reduce pain and muscle spasms in more severely affected quadriplegic children, and facilitates use of braces and orthosis, and also improves patient ease of care as well as maintenance of hygiene and self-care in some of the severely affected ones. The pharmacotherapy are the drugs which are used to treat spasticity. Most of them are overhyped and they are overused as well. The evidence clearly shows that it has a very, very limited role. The two drugs which have some evidence of effectiveness are diazepam and tizanidine, and diazepam has been recommended as a short-term antispasticity treatment, mainly because of its side effect profile, because it causes a lot of sedation, hypersalivation, as well as muscle weakness itself. Whereas tizanidine, this is from American Academy of Neurology practice parameter. It may be considered for treatment of spasticity. It has some evidence of effectiveness. All the other drugs, including dantrolene, oral baclofen, and intrathecal baclofen, as of today, there is no sufficient evidence, but may be used in selected cases. The bottom line for all the antispasticity medications, which are oral or intrathecal, is they are definitely overused and misused most of the times. And for spasticity management, they have very, very defined limited role. Then broadly talking of spasticity management, we have these two groups of children. One is with generalized spasticity and other group with focal or segmental spasticity. So where do you use antispasticity medications? Obviously the generalized spasticity, because they have effect over all the muscle groups. And for the same reason, we don't want to use oral medications in children with focal or segmental spasticity. So this is, I want pediatricians to remember that there's no role of antispasticity drugs in the second group of children with focal spasticity. So there comes the role of botulinum toxin. Because there is no appreciable benefit with the oral drugs, and also functional therapies alone may not be sufficient to attain functional goals. Okay. So what is the mechanism of action? It basically causes chemical neurolysis. the release of acetylcholine from the acetylcholine storage vesicles is blocked by the botulinum toxin. There are different toxins which act on different proteins. As a group, they are called snare complex. So the botulinum toxin A specifically acts on the SNAP25 and sometimes synaptobravin, and it causes, it prevents the attachment of vesicle to the motor end plate. And this maximum effect is seen over first 7 to 10 days, and by 4 to 5 weeks, its effect wears off. After that, again, there's new axonal sprouting and elongation of the motor end plates, which results in new synapse formations. Then, most important question, is it effective? How many of you believe that it is indeed effective? Probably some of you who have some experience with using botulinum toxin. So probably 20 years back, there were a lot of people who were skeptic about its use. But this is a 2010 AAN parameter, which has reviewed the evidence till that date and concluded for localized or segmental spasticity in the upper and lower limbs for children with CP that warrants treatment, botulinum toxin should be offered as an effective and generally safe treatment. Whereas there is insufficient evidence to support or refute use to improve motor function in this population. What does it mean? The spasticity improvement may be seen, but functional improvement, whether it's seen or not, it was not conclusive by that time. But subsequent studies have shown that there is improvement in functional activities as well. It's a Cochrane review on the upper limb spasticity and use of botulinum toxin. Again, the conclusion was combination of botulinum toxin with occupational therapy is more effective than occupational therapy alone to reduce impairment and improve activity level and attaining goals. So this is our own experience in the last 3 years. We have reviewed this recently of children, 55 children who have received botulinum toxin. We had 3 assessments at the baseline using GMFF, FM88, GMFCS level, and the modified Ashworth scale for spasticity assessment. Then month 3 and month 6 assessment. The salient findings were, other than improvement in mass scores, that is modified Ashworth scale for spasticity, we have seen that there was good improvement in GFMF FM scores as well, both in terms of standing, walking, running, or jumping activities. And when we compared with children with hemiplegia and diplegia, again, they have significant functional improvements in both groups of children. This is other interesting thing which we have not specifically looked in the other previous literature, that is, children below 4 years of age had better improvement, better functional improvements as compared with children who have received Botox at an older age.
Ramesh, you have 2 minutes.
Okay, ma'am. Okay, is it so effective as we see in these ads? I'm just going to show some of the videos. The first video is at baseline for a child with quadriplegia with dominant lower limb involvement, lot of crouch. This is at around 8 months post botulinum toxin, and this is around 1.5 years post botulinum toxin. The functional improvements were mainly the independent walking. This is the child with hemiplegia. Again, significant functional improvements. I'm just showing the illustrative cases. And a child with spastic diplegia with a lot of equinus and some degree of scissoring. This is about 9 to 10 months after the around 2 doses of botulinum toxin at 4 months apart. The most important thing is look at the smile of this child while he's walking with support, not much of equinus now. So is it safe? Yes, there were some reports of deaths and worsening of respiratory function in a child with who has received botulinum toxin, but later this one of the largest studies looking at 454 patients concluded that most of the side effects were very minimal and non-fatal. Only in those children who had higher GMFCS level 4 and 5 and with epilepsy had slightly increased risk of these adverse events, but none of them necessitated any changing in the practice. Sometimes it may also be used for children with more severe involvement, but with some realistic goals like ease of caregiving, better perineal care, and to minimize hip problems in the future. But always we should explain to the parents what you are anticipating or what is your goal with botulinum toxin. Dosage, I'm not going to do. So important thing is which cases are to be selected. Important prerequisites are you should have sound knowledge of anatomy and dynamics of motor patterns, because the assessments are not uniform, and role of multidisciplinary team including your rehab team, orthopedicians, and assessment in multiple settings is also important. I'm going to skip this. When not to use botulinum toxin, when there is excessive truncal muscle weakness, you don't want to reduce spasticity in the adductors or hamstrings, which might lead to loss of ambulation. Then spasticity sometimes may help children in ambulation. Like this child who had severe spasticity in the gastrosoleus, if you release it, sometimes they may actually lose ambulation. Fixed contractures is definitely a no-no. Yes, ma'am, done, ma'am. So a team is really important. So just to summarize, effective and safe in focal or segmental spasticity by reduction in spasticity as well as functional improvements. But important thing is you need to select your cases carefully, especially spastic diplegia and hemiplegia are much more likely to respond well. And the importance of multidisciplinary team, both for assessment as well as rehabilitation. Thank you so much.
Dr. Ramesh, just a quick question. Usually a parental concern regarding when you use it, how long does the effect last? And if the effect lasts for what period, and how the recovery during that process, is it sustained, or is it, can the child revert back to the early situation?
Yes, sir. So the effect actually starts around 2 weeks or so, 10 to 14 days, the weakness starts. That's what the induced weakness. And its effect typically lasts for 3 to 4 months. Some of it will come back, but not all. With intensive rehabilitation, you can expect functional improvements. All of it won't come back.
Well, thank you very much.
Thank you.
He's nicely summarized how to use and when to use Botox. But please do remember that also take the message that it has to be used in selective cases and with a particular goal in mind, which has to be functional and for ease of care. I'm sorry we can't take any questions because we've already outstepped the time. And it's my unpleasant duty to keep time. So I invite the next speaker, please.
I invite the next speaker, who will be speaking on chronic ataxia. Dr. Prashant Jowhary is an assistant professor in pediatric neurology in All India Institute of Medical Sciences. I would request him to keep the time for the same reason and specify on the points which are relevant to our clinical practices.
So I'll straight away move to my talk. So I'll be talking about an approach to chronic ataxia. So when this word comes, so what do we mean by ataxia? So that all of us are on the same boat. Ataxia is just any irregularity that is there in the force, amplitude, rhythm and rate of any voluntary movement. So it is not because of any muscle weakness. So most of it is is related to voluntary movements, unlike the extrapyramidal syndrome, which mainly involves involuntary movement. And therefore, it happens mostly in the active phase, when the person is doing some action. Then you are able to see or elicit ataxia much more. So whenever you have ataxia, so we have a very simplified approach. So what we have seen, just like leukodystrophies or white matter disorders, here also you can have a pattern recognition. So you have a phenotype, you label a phenotype, and then get to a detailed history, environmental factors, rule out all acquired and malformations, static causes, and then you start deciphering the etiologies, which are most of the time hereditary, inherited ataxia. So if a child with ataxia comes to you, it will either be an acute single episode, or it may be recurring, or it can be a chronic form with the static, or the disease can be progressive. So today we'll be just focusing on the chronic progressive ataxias, and briefly we'll deal with the chronic static ones. So again, just to summarize the neuroanatomical basis of ataxia, so most of it is just because of cerebellar affection, especially when you have a lot of dysarthria, ataxia, and the Rombergs are negative and the deep tendon reflexes are preserved. However, if you have ataxia along with absent deep tendon reflexes, Rombergs positive, and maybe diminished vibration position sense, it is because of the sensory affection. And when this ataxia is associated with a lot of dizziness and vertigo, then you know it is probably because of the vestibular origin. So once you know that yes, I am dealing with cerebellar ataxia, And just for the sake of time, I'm not be going into the episodic ones. And we know that it is a chronic disease, and the course has been very static. It is non-progressive. So then there's a very specific group that has to be considered, and diagnosis generally, it's very easy, most of the time easy, I'll say. You get an imaging done and just try to look out if there is a structural lesion that has actually led to. So whenever there is an acute or whenever there is an acquired cause to a static insult, the onset will be acute or subacute, and the ataxia would be asymmetric or unilateral. However, if the onset is not very clear and it started very early, but is behaving just like a static insult, then the possibility is that you are dealing with some kind of a malformation or Joubert-like syndrome. So you can get an MRI and it will show. So here the MRI classically shows that there is a molar tooth pattern in the figure which is named as A. And so you know that the diagnosis is Joubert. And the other MRI is showing that there is a severe cerebellar atrophy. So you know, okay, and the diagnosis is pretty much clear. However, the confusion starts when we have a very progressive kind of a disease. So here again, there is a possibility that your child can have some sort of an acquired disorder, especially if it's a very young infant or say 2 to 4 year old kid, then there's a possibility of it being a OMA, that is opsoclonus myoclonus ataxia syndrome. So yesterday there was a talk about it, so I'll not go into the detail of it. The other acquired possibilities would be some form of an ixols. So you have to rule out a posterior fossa ixol, and sometimes even frontal lobe tumors, because its connection with the cerebellum, it can also cause ataxia. So that has to be ruled out. And once you are pretty much sure that you have reasonably ruled out these possibilities, then you start considering that am I probably dealing with some sort of a hereditary ataxia. So in pediatrics, most of these disorders are actually autosomal recessively inherited. A few of them are autosomal dominant. The prominent would be SCA7 and SCA13, and sometimes GLUT1 deficiency. X-linked disorders would be, say, those associated with leukodystrophy, hypomyelinating leukodystrophy, PMD Pelagius Merzbacher, or in adolescents maybe Fragile X-associated ataxia, and then the mitochondrial cytopathies. So now I'll through 3 cases, I'd like to in fact talk to you about what I mean by having a phenotypic classification. So this girl, I'm sorry for the video. Now you see that this child, the gait is, what do you mean by ataxia? So you can very well see that the gait of this child is altered. So there is swaying towards both the sides. It is wide based. So we know, okay, the child has got some form of ataxia, and this child is a 5-year-old, and the ataxia has started for the last 2 years or so. Now this is another child who also had ataxia. Is a 6-year-old child, but had the ataxia started from almost say 1.5 to 2 years of age, which was initially in the form of some head wobbling, and then they were shaking while the child started to sit. And now you can see that there is some sort of an extrapyramidal affection as well. There was evident splaying of the hand, and some upper limb dystonia was there when the child was asked to hold the pen. The intellect was actually preserved in both the kids. Both have had oculomotor apraxia as well. The cerebellum was atrophic in both the kids, and the second child actually had telangiectasias also. So this phenotype the diagnosis is pretty much easy here. So we know that the diagnosis is ataxia telangiectasias. But I want to tell you is that with this phenotype, maybe you have ataxia, maybe you have telangiectasia, or you may not have. And telangiectasia is not a thing that appears very early. It appears, say, around 5 to 6 years of age. So this phenotype, you need to remember that if you have an early onset ataxia without any peripheral neuropathy with cerebellar atrophy and oculomotor apraxia, then you have this phenotype, and then you try to look out for the various etiologies that are responsible for this phenotype. So those would be ataxia telangiectasia-like disorders, ataxia with oculomotor apraxia type 1 and 2, and infantile onset spinocerebellar ataxia. So how to differentiate is also not very difficult. So if you have a clear-cut ataxia telangiectasia-like pattern with raised alpha-fetoprotein, you know that it is 80, and you get to the genetic diagnosis. However, if the alpha-fetoprotein levels are not elevated, then and the telangiectasia is also not coming, and the disease has started very early, then the possibility is much that it is because of an MRE11 mutation, and it is ataxia telangiectasia-like disorder. However, along with this, if you have hypoalbuminemia and hypercholesterolemia, then it is ataxia with oculomotor apraxia type 1. And if you have this without telangiectasias, but the alpha-fetoprotein levels are elevated, then the possibility, and it is a late onset disease, then the possibility is that you are dealing with ataxia with oculomotor apraxia type 2. So this is how, with this phenotype, you can have some differentials, and you can work out on that.
Dr. Prashant, you have 2 minutes.
Yes. This is another child. Here you see, again, there is ataxia, there is wide, but if you can see specifically, then there is an element of peripheral neuropathy as well. There is some high steppage is also evident in this kid. So when you have an ataxia which has started, say, in the adolescent age group with peripheral neuropathy, then you keep a diagnosis of, say, Friedreich's ataxia. Now, this is another child with the same disease and has got peripheral neuropathy and scoliosis. So these are very hard pointers to say that probably this child has got a Friedreich's ataxia phenotype. So the classical age of onset would be between 15 to 25 years of age with dysarthria, scoliosis, autonomic dysfunctions, cardiac affection in almost 2/3 of cases, and diabetes mellitus in another 30% of cases. So with this phenotype, you keep a diagnosis of FA phenotype, and the differentials would be ataxia with vitamin E deficiency, A-beta lipoproteinemia, and refsums. However, if you have associated cerebral atrophy with Friedreich's ataxia phenotype, then you should think of late onset Tay-Sachs, cerebrotendinous xanthomatosis, mitochondrial recessively inherited ataxia syndrome, and spinocerebellar ataxia with axonal neuropathy. So with this FA, you have to see whether the cerebellum is atrophic or not. Otherwise, in Friedreich's ataxia, you will just have cervical cord atrophy. So beyond this, there would be additional patients who will not actually come in any of the two groups. For there, you have to look at the other possible clues from the neurological examination. So if you have a lot of epilepsy, myoclonus, cognitive and behavioral issues, then mitochondrial possibilities should be thought of. And in the extrapyramidal system, if you have additional findings like skin rashes, then refsums, Hartnup disease, if you have woolly fussy hair, then the possibility is that you are dealing with GAN. If you have retinitis pigmentosa, then the possibility is that you are dealing with some sort of a mitochondrial cytopathy. So this is how you should go about. Now this is the third case. This case actually was
Dr.
seen
Prashant,
in
we are just exceeding a time. Can we call
just
it
30 seconds. I'll be
30 seconds, fine.
So this is a child who had ataxia. There were no other clinical findings except that there was hypodontia. So we got an MRI and it showed that there was a diffuse hypomyelination. So this was not fitting into any of the two groups, but however, there was a diagnosis was established based on the MRI findings that the child had got hypomyelination, hypodontia, and hypogonadotropic hypogonadism. So this is how you can with additional information through your extraneural examination, you can still get to an etiology. So investigation is not much, it is MRI, and based on your initial findings, you would plan your investigations accordingly. And if you don't get anything, then you should also look out to rule out CDGs through a genetic investigation or at least a transferrin isoelectric focusing. These are the treatable disorders that one must consider before ruling other disorders. Now the take-home message is that if you have a meticulous evaluation, if you have this approach or pattern recognition, then probably you'll be able to get to the diagnosis in at least some proportion of cases, not all. Thank you.
Thank you, Dr. Prash, for a very nice overview of the ataxias, both hereditary as well as the non-hereditary or the acquired ataxias. Normally, the hereditary ones, we have this ataxia rating scale, ICAR. So do you also use the same to kind of assess the severity of the disease?
ICAS is actually for prognostication. Once you do some sort of a therapy and you see how much the improvement is. Actually, it is much more very evident on your basic clinical examination. So we don't routinely do ICAs unless and until there is some research work in which the patient has been enrolled. Otherwise, I don't think for eliciting cerebral signs, you will need a scale for that.
And juvenile PD also sometimes shows
Yeah,
Friedreich's
juvenile PD,
ataxia
yeah.
type of.
Yeah, exactly.
Because we
So
get patients, some Friedreich's, but when we do the repeat expansion, I do the genetic test, they turn out to be negative. But the symptoms are very much similar to juvenile PD.
Yeah, so juvenile PD is another differential, that and DRPLA. These are other disorders which has to be thought of once the initial investigation don't turn up into a diagnosis. If you don't know about the etiology, then possibly these are the third and fourth level investigation that has to be
Thank you
considered.
very much for a very nice talk.
Thank you, ma'am.
Any question? One question? If there are no more questions, Dr.
Thank you.
Prashant for an interesting talk.
Thank you.
Thank you, Dr. Prashant.